Welcome to Brainthropology. Let's talk about our amazing brain and the issues that get us stuck. We all have those moments where life gets overwhelming. It can be related to injury or illness, or an issue with your kids, or just because life is crazy and we need a little help and encouragement. Our team of therapists, expert guests, and clients are here to deep dive into the topics that matter most. We will share information with our listeners that encourages, educates, and empowers.
This episode is brought to you by Galaxy Brain and Therapy Center, helping clients live their best lives by implementing strategies such as those discussed in this podcast. Galaxy Brain and Therapy Center is located in Ann Arbor, Michigan, serving southeastern Michigan for in-person and community-based services. Out-of-state virtual and teletherapy services available for OT, PT, speech, mental health, and mindfulness. Check out their website at galaxybraincenter.com.
Hello, everyone. Welcome to the Brainthropology podcast. We have a great show planned today. It is the second podcast in a two-part series. The first was on anxiety. If you haven't listened to that, it was a great episode. You should take a listen. But today's podcast is on depression. We are very excited to have such an experienced clinical psychologist with us today, Judy Malinowski. And Courtney Wang and myself, Debbie Loftus, are co-hosting today's show. As I said, today's topic is about depression. Really a topic I think hits home with so many people right now, especially with what's been happening in the world with the pandemic. In doing some research for this podcast, I found out that the incidence of depression was so much higher than I expected. According to the National Institute of Mental Health, depression affects an estimated 1 in 15 adults in any given year. And 1 in 6 people will experience depression at some point in their life. I'm really excited to dig into this and find out more about it. We're so grateful to have someone in studio with us that's an expert on this topic to share her expertise with us. So thank you, Judy, for being here.
My pleasure.
So, as always, before we get started, we like to encourage people to start their day with gratitude. And one way that we do that at Brainthropology is we share a personal or professional positive. Today, I am grateful for medical advancements. So I know the people at the table here know this, but my dad just had a reverse total shoulder replacement, and I was so grateful for the amazing medical staff and how advanced technology has come to be able to make him have a new shoulder and be the bionic man. So I'm so grateful. Judy, what's your positive today?
My positive is that over the last couple of weeks, I've been able to spend some really great quality time with my grandchildren and my children, and that always gives me a grounding. You know, you talked about anxiety a little bit. That's my grounding is, just connecting.
I love it. What about you, Court?
I think mine will be my youngest daughter, Lainey, her 8th birthday party. It kind of brought me so much joy and chaos. At the same time. We had planned this little party before school started, and we just wanted our neighbors and her good friend, and we were going to do one other family group to come over. She goes to school, realizes how much she missed her school friends, and hand wrote invitations to a bunch of kids that randomly showed up at the party. And it was beautiful. And it just it reminded me of her as being a little Courtney sometimes, because we're both social creatures. So it was fun and chaotic and beautiful and a very Laney party.
I think you need to elaborate on that. So I get a text from Courtney saying this is what happened today and how parents were contacting you.
Yeah, parents were screenshotting this handwritten information with my phone number that she was providing for people. So I was super proud. She knew her phone number. Yay, Lainey. But then I was a little caught off guard when I had planned this elaborate treasure hunt based off of her favorite novel. I wrote a sub-story and made clues and spray-painted dragon footprints in my yard. Oh, wow. And I didn't have enough prizes for my 2 kids to actually take after all the extra people came. So now I'm redoing a Harry Potter-themed treasure hunt this weekend with a new subplot from a new story, but it's going to go
I'll take
well.
the old one, Court. I'll have your leftovers. I love it. I love it. All right. So let's dive in. I know during our last podcast, Judy, you did a great job explaining what anxiety was. And today we're talking about depression. And I think many times these two diagnoses go together. So can you tell our listeners the main difference between anxiety and depression?
Well, depression is a mood disorder. I look at anxiety as being more of a thought disorder in the sense it's a disorder of our thinking. Of course, there is a mood component to it as well. But when we look at depression, it's a sense of hopelessness and helplessness. There's this almost lack of joy of life. And it can be either a major depression where we go into just the dark place where we feel overwhelmed, we can't figure out how we're going to function, or we can have what's called dysthymic disorder, which is we never truly feel happy. We're just kind of blah and apathetic and flat. So depression can show up in many different ways. And just like with anxiety there can be a depressive quality to it. Because if you're anxious all the time, you're not going to be really happy with your life, and there can be some depression. But with depression, there also can be anxiety because we feel as if our life is out of control. And anytime that happens, it makes us feel that sense of panic or anxiety. So they're hand in hand. One doesn't overwhelm the other one, but we have to be able to tease out what's the primary, what's the secondary, and how we're going to treat it.
Sure. And from an OT perspective, we always think of activities. So when I think of depression, I think of feelings of sadness or a loss of interest of activities, and it can lead to a variety of emotional and physical problems that can decrease your ability to function at work or at home.
Right.
So personally, I know some of the basic symptoms, right, that I think everyone's familiar with. So the basic symptoms of depression, like feeling sad or having trouble sleeping. But what are some of the common symptoms you see present with people who have depression that might not be as common as we think? So, I guess one that I would think of would be like loss of energy or increased fatigue.
And those are interesting because those are actual physical manifestations of this mental illness, correct? Pain. Physical pain for a lot of people, they don't connect it that it could be due to their depression. And as well as we know that if somebody is in chronic pain, they oftentimes have symptomatology of depression because of the draining on their system, the continual cortisol buildup and how the body responds to that. Part of depression is stress, is that constant, being pressured. And we don't realize when we become apathetic or when we get that sense of helplessness or hopelessness, that's all part of depression. So we have to be able to look at the triggers, the precursors, so to speak.
Sure.
Is it, biological, psychological, emotional? What is it? It's all of it. And so we don't just treat, as far as my practice, I don't just treat the one aspect. We have to talk about all of them. Loss of appetite, poor sleep, like you said, loss of energy, physical pain, worry. All of those things are aspects of depression.
Yeah, and some of the emotional, feeling worthless or guilty, and loss of interest and pleasure in activities that you once enjoyed. That's one that we see a lot in therapy as a comorbidity. Depression can present with traumatic brain injury or with stroke or some of these things that might be at the root as well. So as far as symptoms and being diagnosed, so I know with anxiety, you had said the primary care physician is a really good resource. Is that where somebody would start as well if they are feeling depressed?
It oftentimes is, because now with all of the different changes in our medical field, primary care physicians are required to give screening tools to their patients when they come in. The one for depression is the PHQ-9, the one for anxiety is the GAD. And so these tools are used for screening and for treatment and for referral. So they're really very, very important as far as somebody being able to go, yes, I've lost a sense of joy. I have a sense of hopelessness. I'm not sleeping well. I may have suicidal thoughts, all of those types of things. And then the physician can look at that and say, okay, we need to do something about this. This can't go untreated. And then that's where the referral source starts to happen. So
if somebody's having a depressed thought, it is different than depression, right? So with diagnoses, typically you would wait, 2 or more weeks? And then doesn't it represent a change in your previous level of functioning for diagnosis?
Correct. There is that time period. Correct. Because many of us, I don't know any human being who has a full range of emotions, who has not felt sad or hasn't felt that sense of being overwhelmed. That's part of life. We might have multiple stressors going on. We might have a loss that we're dealing with. We've had numerous losses that have happened over the last how many years that we've had to function with. So we need to look at it across a continuum. How are you doing long term? Is this an isolated incident, or is this becoming chronic? So acute, chronic, those are the types of things that we have to look at.
And I think you brought up a really good point. So I know there's a difference between sadness or grief and depression, because I know sometimes I've heard friends or family that have experienced a loss and they're grieving and they tell me that they feel depressed, but there is a delineation. Can you tell me a little bit more about that?
Grief is a natural response to loss. And I think that's what I really want to emphasize. It is natural. When we go through, and we have different types of losses. I saw some depression happen with my teenagers that I see in practice last year, the seniors especially. They were coming to the end of being in high school, and there was part of them that was so excited, but then part of them was going through a grieving period because it was a huge change. And there's always grief when change occurs, correct?
Oh, absolutely.
Because we have to let go of something.
Yeah.
And that's what started to happen. What we have to understand is there is a big difference between grief and depression. Now, if grief goes untreated or unaddressed, it can devolve into depression. But part of grief is understanding that I'm going to go through the stages. I'm going to go through bargaining and denial and sadness, right? Some anger, and then I'm going to go through acceptance, and then the final stage is making meaning, because that's very important for human beings. We need to make meaning in our life, and that's another aspect of depression. We lose the ability to make meaning in our life. What is this all about? Life is just nothing.
Yeah. So it sounds like being sad is not the same as having depression. So the grieving process is natural and unique to each individual, and it shares some of the same features of depression, but it's not the same thing. Both grief and depression might involve intense sadness and withdrawal from usual activities, but they're different, and that's important to recognize. So with depression, what would you say some of the risk factors are that, several factors that can play a role in depression?
Just as in anxiety, we have the aspect of nature versus nurture, right? So I may have a genetic predisposition for depression, and I can look at my family history. I can look at my culture. There are many cultures that might have a more negative view of life just because of what they've had to live throughout the ages. So that pessimistic, almost negative way of viewing life. The glass is always half empty. There's no optimism. That's those cultural things, genetic things, on top of if I'm raised in a family where there's a lot of negativity, a lot of sadness, perhaps my mother or my father might be going through depression or even bipolar depression, or there's trauma. That's one of the things that is so important. When a client comes into my office, one of the key things I want to find out is, where's the trauma? Is there trauma? Because many clients can go misdiagnosed. They may be diagnosed with depression when really what they have is post-traumatic stress disorder with those mixed features of anxiety and depression. So that's why diagnosing is so important, because we can't do correct treatment if we don't have the correct diagnosis.
Absolutely. And then biochemistry, I think, plays a difference. Yeah, there's a difference in certain chemicals in the brain, and that can contribute to symptoms of depression as well.
Well, when you're talking about biology, I think one we also have to address is the gut-brain connection.
Oh, that's so important.
Right? Our diet. Serotonin is broken down in the small intestine through the digestion of folic acid. So if my diet is not correct, if I'm not taking in enough nutrients, or if I have a compromised digestive system, leaky gut, whatever you want to call it, I am not going to have the abundance of neurotransmitters that I need to have, and I won't have access to them.
Yeah, that's so important. So some of the risk factors that we hear about, when I was researching for this podcast, some of the common ones, environmental factors that you talked about, having continuous exposure to violence or neglect or abuse, touching that trauma piece. And then also, as far as genetics, I read a statistic that and there was a study with identical twins, and if one identical twin has depression, the other has a 70% chance of having the illness sometime in life, which is so interesting.
Well, what's interesting about that is for those of you who have that been through a psychology course, of course, we talk about the twin studies where the twins were separated at birth, and what happened, it showed up that they were so closely correlated regardless of where they were raised.
Sure. Yeah, that's very interesting. Is there a certain age of onset that you see with depression?
That's interesting because I've seen children as young as 3 and 4
really
manifest depressive symptoms, the isolation, the lack of talking, the poor sleep, the poor attachment. That's also an aspect of it, that fear response of being detached from a parent or whatever. And, it all plays a part, that pessimistic attitude that you can hear in some kids that you don't hear in other children, that worry, or everything looks negative, or everything is too much, or, they don't make friends easily. So yes, it can show up in children at any age.
Wow. What about as far as women versus men? Do you see more women or more men present?
I tend to see more women.
Okay.
And I think we always have to be conscious of where our statistics are coming from. Mm-hmm. I'm not sure if I'm seeing more women because women are more predisposed to having depression because of our emotional state.
Sure.
We could talk about brain chemistry all day long.
Right.
And men may suffer as greatly with depression, but they go untreated. Mm-hmm. And so if I go untreated, then I'm not going to be part of the statistical analysis and the numbers, right? The stoicism, the pull yourself up by your bootstraps, strong.
I was just going to say, why do you think that is?
Oh, I think it's cultural, societal. I think it's anthropological. You can go all the way back to the idea of, I don't have the luxury of being depressed. I got to go out and make a living. Mm-hmm. And oftentimes with men, what it'll show up as is anger. And so that gets completely skewed, right? Mm-hmm. We have somebody that may show up more angry. We're not seeing that underneath that could be depression.
Sure. I think one of the most important things that I want to make sure we spend more time on today, I had so much fun with that anxiety podcast that I want to make sure we save so much time today on treatment strategies, because I think one of the most important things to talk about to answer the question is, how is depression treated? So one of the most important things, Courtney, we talked about earlier is to have resources. So we are seeing the new 988 number everywhere. So, if you or someone needs support, you can call or text the 988 number, or you can chat at 988lifeline.org. And we'll have all these, this information in our notes on the podcast. But I was so surprised on a personal level. This year, my son is a junior in high school, and they got their student IDs, and the whole back of the student ID is an advertisement for 988 suicide prevention hotline. And that just tells you where our culture, our society is right now. And it's so scary.
And I would say it's really important to put that number as a contact in your phone, because when you're going through a hard time, you need easy access to that number, and you may not remember it when you're going through a hard time. But also, if you have a friend who's going through a hard time, sharing that contact card and giving them easy access to it. And I've used it in sessions with clients because I want them to feel safe calling or texting that number right away. And once we've done it once, I think it relieves that anxiety of trying to do that if they really need it.
Yeah, absolutely.
I think one of the key aspects to kind of bridge depression and suicidality is that oftentimes when people are in a very, very deep depression, they may not have the level of energy in order to follow through with a suicidal act. It's when they start lifting out of their depression somewhat, and we're thinking, people around them are thinking they're getting better, but they may be more vulnerable at that time to having an act of suicide than they were when they were in the deepest part of their depression.
That's
because
interesting.
Now they have energy enough to follow through. And this is what is so devastating for people who are left behind, because they didn't see that sign. Mm-hmm. So just know that just because somebody is pulling out of their depression does not mean that they're not vulnerable.
That's really important information. So we had a conversation before, and you were telling us about some resources. So was it NAMI?
Yes, the National Alliance of Mental Illness. And what's great about it is that it has supports not only for individuals that have mental illness, but for their families and the people that are their support systems. And it's, Michigan has many chapters, and it's very, vibrant and very active, and everyone that I have referred to it has had great experience.
Oh, that's awesome. And just to go back to that 988 number, I want to encourage people. I've had people tell me about their experience that it's not only for the person that is feeling depressed, it's also for family members and support caregivers. So you can text and you'll get an immediate text back. So that's really important to share as well. As far as more treatment strategies, and I hope the bulk of this podcast, that's what we talk about, as far as medication goes with depression. We talked about brain chemistry and how it may contribute to an individual's depression and may factor into their treatment. How does it work with medications directly related to depression?
Well, we have a slew.
There's probably a Bible full, right?
Right, a Bible full. It is so funny because, as I said in the earlier podcast, I've been doing therapy for many, many years. And it's just amazing to me. When I started, there was a couple of antidepressants. It was fairly new, the ideology of these new, what we call specific serotonin reuptake inhibitors called SSRIs. Before that, there were MAO inhibitors, which tended to have a lot of side effects, and you had to watch what you ate and all different kinds of things, or the tricyclic antidepressants. So this new, and there's not as new anymore, have benefits. I do believe that. Mm-hmm. But I don't, as I said before, I don't think they're the only thing. I think taking a medication without utilizing therapy, without utilizing strategies and tools, is only going to give the person the false sense that this is all they have to do. Mm-hmm. If you're not combining it, and that's what I really so appreciate about where I work and where I've always worked, is that if you are on medication, with a psychiatrist, you have to be seen in therapy. There's not one or the other. It is a combination of both, because part of it is the maladaptive thinking, the negativity, the ability to reframe your thinking into something more positive rather than going towards the negative.
So it's interesting because I know in different cultures, in different countries, that primary care physicians can give antidepressant medication. So is that the case in the U.S.? It is.
Yes.
It is.
And most primary care physicians know a certain amount and the certain medications that they may be comfortable with, the older ones like a Prozac or a Zoloft or mm-hmm. a Lexapro or any of those types of things. But when this is the issue with antidepressants, and anybody listening to this podcast and who's had experience with antidepressants knows this. It's trial and error. Mm-hmm. We don't know what's going to work. We don't know the right fit. There's so many other factors. There's DNA factors. There's this factors. And I wish, and I believe wholeheartedly that we're going to get to the point where we can have much more specific testing that will pinpoint what the right medication will be for that person.
And that's already started. Because I know gene site testing exists, yep. which is helpful.
Yes, and that's so exciting because there is nothing more disheartening for someone who is going through the rounds of, let's see what doesn't work. Mm-hmm. Right? We're going to try this. Well, it doesn't work. Let's switch. And it's not an easy process to switch. Mm-hmm. You're weaning off of one, coming on another. You got side effects. And that's where so oftentimes individuals will just say, I've had enough. Mm-hmm. This is too hard. I'm not going to do this anymore, because they either can't deal with the side effects of the medication, or they don't want to be on this medication merry-go-round that they're being put on just because we don't have the technology currently.
Can you talk a little bit about the importance of being consistent with whatever treatment plan you're on? And also, if you're having issues with your medication and you want to go off them, the benefits of talking to your physician or psychiatrist and trying something else, because there might be something that doesn't have the side effect that you're having.
Correct. These are not an every so often type of medication. you need to commit that you're going to take them. It usually takes 10 days to 14 days for it to get up to some sort of therapeutic level. And then you'll notice by 30 days, it's a different level. By 60 days, you're pretty much where you're going to be. So it's a long-term, 60 days for people that are feeling really bad is a pretty long-term commitment if you think about it. Most of us were raised that we want immediate gratification, and we're not getting it with these. Just saying. Yeah. And then the other aspect of it is if you are on these medications, under no circumstances should you interrupt use, radically. There's no cold turkey off of this. You will throw yourself back into a really bad place if you do that. And all you have to do is ask somebody who's done it and they feel like they're losing their minds. Yeah. Right?
Yeah. My clients call it brain zaps.
Oh, definitely brain zaps. It's such an odd experience. So you have to work closely with your primary care physician or your psychiatrist to be able to wean off of them or substitute and go on that protocol. And that's why, they're experts at it. This is what they do. And you've got to trust them. And you've got to be honest. You've got to say, I haven't been taking it regularly. Well, no wonder you're not having benefits, you know? And I hear it all the time. I hate taking pills. I hate the idea that I'm on medication. This makes me feel like there's something wrong with me. Talk about the self-stigma that we have of doing some of these things to address. No one would say, you know what, I don't want to take my insulin today.
Sure.
Right? Or I don't want to take my blood pressure today. I'm just going to let it go radical. But I'm telling you, it happens with antidepressants all the time.
Yeah, and from an OT perspective, we have clients, and I've mentioned this before, that many times depression or anxiety is a comorbidity. And our favorite word, compensatory strategy, if people are having a hard time, so they're not purposely missing their dose, but they're having a hard time remembering when to take it, because sometimes it's twice a day, sometimes it's once a day. There are so many strategies out there that you can Google strategies to keep you compliant with your medication. Some simple strategies that we've used, Courtney and I have many times with clients, is using your phone timer. And there's apps that you can use that, every 4 hours, please remind me, or twice a day. You can even ask Siri, hey Siri, set my reminder for 8 a.m. and 8 p.m. And you can label that with the exact medication so there's no confusion. There's also medication boxes that from the traditional, 7-day with the MTW, Monday through Friday, that some people find very beneficial, and then they refill it on Sunday to make sure they don't miss a dose. And then there's technology. So Courtney, that's your expertise. Can you give us some strategies that, from a technology tip standpoint that might help with compliance?
Sure. One of the ones that I recently got for myself that I love is I have a new bottle that I bought on Amazon, and it has a timer on the lid, and it'll tell you how long it's been since you last opened your bottle. And it's amazing how it just is a very, very simple thing. I personally don't need an alarm because I take it at night before bed, but I can look at it and be like, oh crap, that says 48 hours. I missed one. And so it helps me know, because when you take a medicine day after day, sometimes it's hard to remember that you had just taken it 24 hours ago, because is that memory from yesterday or 2 days ago? You've mentioned some great apps that are out there. Alarms are amazing for this kind of stuff, but look around. There's also really great ones that actually will call a friend if you don't take it. So if you're trying to help a loved one take medication, there are pill boxes that have their own alarms, and then they're also connected to the internet, so that if you forget to take your medication or your loved one forgets to take a medication, it has a list of people it will call or text and let them know about that, because we know the importance of taking medications consistently. And these medications are very important because they take a while to titrate, which means become therapeutic and to work in your system. And missing them can feel very, very uncomfortable. And that's the last thing we want when someone's going through depression.
Absolutely. So we put a focus on medication, but I want to be clear that we have a similar view, I think, as professionals, that we encourage people to couple that with psychotherapy. So again, it's changing your brain to be more susceptible and open to use therapeutic techniques. Would you agree with that, Judy?
Correct. And I think there's also, and I understand when somebody is in a deep depression, they don't have the desire, they don't have the energy to do other alternative things, exercise being the number one. You can ask my clients, I'll I'll beat the drum about exercise.
Right.
Because what I know is you always feel better. It increases blood flow. It increases endorphins. It pumps out dopamine. It's our body's way of really healing us from all of those different, moods that we might get in. But if you don't have energy to exercise, you're not going to get the benefit because you just can't even drag yourself out of bed sometimes.
Yeah.
So those are some of the things. If you want to talk about other things, having a light, the mood light.
I love it. The happy light.
The
We've
happy
used
light.
that. I get
Absolutely.
sad in the winter. So I read online an article, get a happy light. I think I got it from Costco,
sure.
which they are not an advertisement, but just letting you know, you can get them cheap on Amazon or Costco. And
Well, and here in Michigan, we have a high level of seasonal affective disorder. We call it SAD. And what is that? Because we have gray days. And after you've got a series of gray days without sunlight and vitamin D, you're going to start feeling down in the dumps. We call
Sure.
it cabin fever or all of those types of things that we've called it in the past. But it's a real thing. The shortened days, when daylight savings time is over and we're hitting that on November, we know it's going to be, wow, I go to work in dark, I go home and it's dark. Where's that place for me to get my UV rays type thing?
Sure.
So taking a vitamin D supplement is very important for us. Getting good rest. The trouble is with depression, sometimes people sleep too much. Mm-hmm. So we've got that fine line of how much rest is enough. Am I getting healthy, rejuvenating sleep, or am I escaping from reality by pulling the covers over my head?
Sure.
So all of those things.
And I think sleep brings up that point that my kids, if they listen to this, they're going to be so annoyed because they're going to be like, Mom, you didn't mention it again. Really? But technology. Can you talk about technology and the effect on depression?
Well, it's so interesting because people will say to me, I'm having a hard time falling asleep. So what I do is I sit in bed and scroll. And I go, well, hello,
ding, ding, ding.
self-fulfilling prophecy here. You're really doing it. But again, that technology, just the way it fires off the neural pathways and creates that psychic storm, will leave us feeling completely drained, and we don't even realize it's happening.
And I think we can replace some of that technology need. I find it's easier sometimes to replace a habit than to just totally change and stop scrolling in bed. So one that I've used with clients, and I'd like your insight on this, is sometimes they'll go to sleep listening to the Insight Timer app and a meditation app because they have go to sleep meditations. I had a baby, my very firstborn Zoe. That girl never slept. And so for me to get through it, I started listening to audiobooks at night. And it's amazing to this day. I go fall asleep within 5 minutes of turning on my audiobook. But what do you think about replacing that technology habit with something like that?
I strongly recommend that. In fact, Insight Timer is my go-to. And what I love about it is that it'll shut off on its own. So you don't have to worry about, I've got to wake myself up to shut my app off. It'll take you through a 10, 15, 20-minute sleep meditational app. And 9 times out of 10, what I hear is, wow, I don't even remember getting to the end of the meditation. I fell right to sleep. Mm-hmm. And for those of you listening, having a sleep hygiene routine is vital. The sleep we receive between 10 p.m. and 1 a.m. is the most important sleep of the night. Mm-hmm. It's when we go into that deep REM, that deep stage 4. After we've gone through that, because we've gone through a couple of different 90-minute sleep cycles, and so we're getting that rejuvenation, we're getting less and less deep sleep as the night goes along because we're getting ready to get up and be roused for the day. So when I hear people going, well, I don't go to bed until 2 o'clock in the morning, well, I know that you're completely throwing off your circadian rhythm, which is not going to help you function during the day.
Well, in a good sleep routine, I think in my world, what that looks like is I talk to my kids, we brush their teeth, we read a book, they lay down, I then brush my teeth, I then turn on my Audible book, and I go to sleep. But it's those habits that tell your body it's nighttime. Because otherwise, if we start turning on computers and this kind of stuff, we're saying, hey, wakey, wakey, here's some light for you. And so just kind of finding ways, you can probably Google and search what some good sleep routines are, but just knowing that those are it's a ritual. that you develop so that your body says, good night.
And so things you want to do and then things you want to avoid. So sleeping with the TV on is a big no-no.
Big no-no. I'm a firm believer that TV should not be in the bedroom.
Me too.
I'm just going to leave it at
I
that.
know. My husband totally disagrees with me, and I won on that one. I'm grateful. Yes, I just cannot have it in the bedroom.
When we understand that darkness kicks off melatonin and light pulls out dopamine. So it makes sense biologically of why would I want light on if I want to be able to fall asleep and have my melatonin kick in.
Absolutely. So 2 or 3 other areas of treatment that I don't think are as common, but I'm sure people have heard of it, and I would love just to give a little description. So EMDR, ECT, those are 2 terms that in the therapy community we know about, but I don't know that our listeners will be, know the definition. I would love for you to talk about that.
EMDR is eye movement treatment. Okay, so a trained practitioner, because they have to go through a long period of training, learns the techniques of utilizing our eye movements in order to access those parts of the brain that can help us build new neural pathways. And it's also extremely beneficial for post-traumatic stress and trauma because it accesses memory. So oftentimes what we have to look at depression, we have to really weed out what are the memories that might be connected to this. Is there trauma going on?
Sure.
Was there any level of abuse? Was there any level of isolation or abandonment or any of those issues? So EMDR is a non-invasive, very reputable type of treatment that, again, a trained practitioner needs to utilize. ECT, and for those of you that are my age, so we're going back, it's not like it used to be. It's not like One Flew Over the Cuckoo's Nest. That's not what they do anymore. It's very specific and targeted to certain areas of the brain where they're able to take an electromagnetic shock. Again, this is done by a physician, a psychiatrist oftentimes. They're highly trained. They know what to do, and it's for those individuals that have such deep-seated chronic untreatable depression with any other form of treatment. This is kind of one of those things that you go, I got to do something. And so I'm going to do this. Within this area, Henry Ford does have an ECT clinic. So if you're interested in that, that would be who you would want to contact.
That's great to know. So overall, beyond the treatments that we talked about, from an OT perspective, as I mentioned, we see clients that have a diagnosis of depression along with another diagnosis, which we specialize in brain injury. But we try to focus treatment on education on strategies to help alleviate some of the symptoms of depression. So some of the things we talked about and some other things we encourage people to do. So try to get some physical activities. Even 30 minutes a day walking can boost your mood. Try to maintain a regular bedtime and wake up time. Eat healthy meals. And now having the internet, you can Google, 3-ingredient healthy meals and they'll come up for you. Do what you can as you can. So really decide what has to get done and what can wait. Give yourself some grace. Try to connect with other people and talk with people that you trust about how you're feeling. Postpone important decisions. So when you are in the heart of a depression, really postpone the important things like getting married or divorced or changing jobs until you're stable, until you feel better. And one that we didn't talk about is avoid using alcohol, nicotine, or drugs, including medications that aren't prescribed for you. I think that's really important. And do you see that in the clinic? Is that something that you address? Yeah.
For sure. I can't work with somebody on what's going on with them if they're discharging their energy with alcohol or drugs. That's their medication. That's their coping strategy. And so talk therapy or any type of therapy is never going to work as quickly or as consistently as alcohol or drugs. That's why people use them. They're trying to change their consciousness. I want to alter my state. The trouble is that alcohol is a central nervous system depressant. Mm-hmm. So I'm taking a depressant to combat my depression. Not a good combination.
Right. So the only thing I can think of that we didn't cover that I know listeners will want to know is if you have a loved one that's diagnosed with depression, what is the best way to help?
First off, it's not about you that they're depressed. That is the key thing that I want to share with people. If you have someone in your life who is going through depression or any other type of struggles, it's not your fault. And it's also not your responsibility to be their therapist or to treat them or to rescue them. You can't. Mm-hmm. You can support them strongly in getting the help that they need. If they need you to go to an appointment with them, go. It doesn't mean you have to go into the office with them, but you can sit in the waiting room. You could drive with them. You could be that support system that they need. But always understand that you, as a loved one, have limited capacity. You're not their therapist, you're not their doctor, and you have to make sure that you're taking care of yourself and not getting pulled down into the issues at the expense of your own mental and physical health.
Yeah. So you really push them to get help to their mental, to get support for themselves, which thereby is helping you. That is a lot of information, people. Let's do a quick review of what we talked about today. So we defined depression and how it's different from anxiety. We talked about symptoms of depression. We talked a little bit about the difference between depression and grief. And we talked about the risk factors and treatment of depression and gave out a very important resource. Again, I want to reiterate, if you or someone you know needs support, you can call or text 988. Or go to 988lifeline.org to find some more information. And 988 is a suicide and crisis lifeline. It's a national network of local crisis centers that provides free and confidential emotional support to people in suicidal crisis or emotional distress 24 hours a day, 7 days a week in the United States. And it's also a support for family. So, Judy, we want to thank you so much for joining us today.
It was awesome.
Yeah, we hope our listeners enjoyed today's podcast, and we hope that in some way it will help someone who needed to hear this information. If you feel the information we talked about today was helpful, please feel free to share this podcast with friends and family. And as always, we encourage you to be courageous and move forward in your day with hope, joy, and purpose.
While we love what we do and are as passionate as they come, the information on this podcast and discussion is for educational purposes only and should not replace professional medical advice. Please consult your own healthcare provider if you are seeking medical advice, diagnoses, or treatment for you or anyone else. We do our very best to provide correct information, but please understand science and medicine is ever-changing. We welcome feedback, comments, suggestions, or correction of errors. This disclaimer applies to any guest or contributors to the podcast or blog.